Hello, my name is Manuel Loja. My topic is Romosozumab or Alendronate for fracture prevention in women in osteoporosis. Definition: Osteoporosis is a clinical condition characterized by decreased bone mass and deterioration of the microscopic architecture of the bone, but circumstantial increase bone fragility and consequently the risk of fractures.
Hello. How is your wrist today, Mrs. Wilson?
It's more comfortable now that I have a plaster cast on.
That's good. How did you break your wrist?
I just knocked my arm on the edge of the table. I was very surprised when I broke my wrist.
Do you usually have problems with your bones?
The doctor said I have osteoporosis, but I don't know what it is.
Some people call osteoporosis having thinning bones. It happens when your bones lose calcium and become filled with small holes.
Oh, I see. Is that why I broke my wrist?
That's right. If you have osteoporosis, your bones are not strong and can break very easily.
What can I do to make my bones strong again?
You'll have to take a tablet to slow bone loss.
Okay, is that all?
You should also make some changes to your diet.
What sort of changes?
Try to eat food which contains lots of calcium and vitamin D.
What sort of food should I eat?
Dairy foods, like milk, yogurt, and cheese, have a lot of calcium. Fatty fish and egg yolks have a lot of vitamin D.
So, I have to take tablets and change my diet. Is that right?
That's right. You also need to do some exercise every day.
I like swimming. Is that okay?
No. They must be weight-bearing exercises, like walking or keep fit classes.
I see. Then I'll ask my friend to come walking with me.
That's a good idea.
Application in medicine. The new drug Romosozumab is marketed under the name Evenity. It has been continuously developed by the American biotechnology company Amgen, short for Applied Molecular Genetics, and the Belgian company UCB, acronym for Union Chimie de Belgique. Romosozumab stabs the bone, simulates osteoblastic activity. Without simulation of the plastic activity, has happened with the parathyroid hormone and the pharmacological look alike that has been shown in clinical trials.
Sclerostin is an osteocyte-secreted glycoprotein that inhibits the Wnt and bone morphogenetic protein signaling pathways, which stimulate osteoblast proliferation. Patients with inactivating mutations in SOST, the gene that encodes sclerostin, have high bone mass and resistance to fractures. In a previous trial in postmenopausal women, Romosozumab, a humanized monoclonal antibody that inhibits sclerostin, reduced the risk of fractures as compared with placebo. However, Romosozumab has not been compared head-to-head with bisphosphonates. In the ARCH trial, an international double-blind study, investigators randomized 4,093 postmenopausal women with osteoporosis and a previous fragility fracture to monthly subcutaneous injections of Romosozumab or weekly oral Alendronate for 12 months, followed by open-label weekly oral Alendronate in both groups. the primary outcomes were the incidence of new vertebral fractures and the incidence of clinical fractures, which included symptomatic vertebral fractures and non-vertebral fractures. At 24 months, 6.2% of those in the Romosozumab group had had a new vertebral fracture, as compared to 11.9% of those in the Alendronate group. After a median follow-up of 2.7 years, the incidence of clinical fractures in the Romosozumab group was 9.7% versus 13% in the Alendronate group. Patients in the Romosozumab group also had fewer non-vertebral fractures. Patients in the Romosozumab group had an increased incidence of serious cardiovascular adverse events during the double-blind period, 2.5% versus 1.9%. Osteonecrosis of the jaw occurred in one patient in each group. 2 atypical femoral fractures occurred in the Romosozumab group versus 4 in the Alendronate group. The results of this study of postmenopausal women with osteoporosis and high fracture risk indicated that starting with Romosozumab treatment for 12 months before Alendronate significantly reduced fracture risk as compared with treatment with Alendronate alone. Full trial results are available at nejm.org.
Number 1. Dual-acting osteoporosis drug.
Suffering from the bone-weakening disease, people with osteoporosis are at risk of a broken bone with the simplest task. Daily activities like walking or lifting a grandchild can become a concern for injury. Unfortunately for millions, loss of bone occurs silently and progressively, often without symptoms until the first devastating fracture. Since 1995, drug therapy for the condition was limited to anti-resorptive agents, medications to slow down bone loss. In 2002, anabolic medications became popular, acting to increase bone formation by stimulating the cells that build bone. The stimulation seen with these anabolic medications, however, increased bone resorption as well, mitigating some of their reinforcement effect. But a new drug is remedying this catch-22. FDA approved in April, patients receive 2 injections of Romosozumab every month for a year. The treatment works by blocking the protein sclerostin, which inhibits bone formation. This allows an increase in new bone, while also decreasing bone resorption or bone breakdown. These developments present a new agent that builds more bone than any previous osteoporosis drug. In an active comparative study of women with postmenopausal osteoporosis receiving the new drug or its anti-resorptive predecessor, risk of spine and hip fracture in the new drug cohort was reduced by 50 and 38% respectively. Patients are getting back to daily activities without risk. The treatment is providing strength not only in bones, but in spirit.
Pros and cons. The technical information indicates that Romosozumab is only recommended for postmenopausal women and high risk of osteoporosis fractures, with a warning of a small but significant increased risk of heart attack or stroke, according to experts. It is an important drug since it is the first one that seems to directly stimulate the information of the bone tissue.
Risk factors for osteoporosis include being female, being older, postmenopausal, of Caucasian or Asian background, having a low dietary calcium and vitamin D intake. Treatment options for osteoporosis include calcium and vitamin D, and those are, of course, the mainstay of all treatment. But additional choices that we have available include bisphosphonates, teriparatide, and denosumab. There's a new drug in the pipeline. It's a monoclonal antibody known as Romosozumab, which is a very exciting treatment option. It's an anti-sclerostin antibody that increases bone formation. The Romosozumab study was published earlier in 2014 in the New England Journal of Medicine. This was a dose-finding study. After a one-year period of time, the Romosozumab increased bone density to a greater extent than the best treatments that we currently have, including teriparatide and Alendronate. Well, I think it's important for physicians to think about the diagnosis of osteoporosis, especially in elderly patients and also in those who've had a fracture. It's important to think about the diagnosis and order a bone density to measure bone mass, and then initiate treatment. It's important for physicians to be aware of current treatments for osteoporosis, but also to realize that new treatments are on the horizon, which likely will be even better than the ones we currently have.
Arthur Lau reporting from RoomNow.com from ACR 2019 from Atlanta. I want to give an update on a very interesting oral presentation that I heard today on osteoporosis, which was a subgroup analysis from the FRAME study. Just to remind everyone, the FRAME study was a phase 3 randomized controlled trial in postmenopausal women where patients were randomized in the first year to placebo or Romosozumab, and everyone crossed over to denosumab in the second year. So this was a subgroup analysis looking at degrees of chronic renal disease in patients of the study. So they broke down the renal disease based on mild with an eGFR 60 to 89, moderate 30 to 59, and severe 15 to 29. Of note, the vast majority of patients were in the mild to moderate group. There were very few patients in the severe chronic kidney disease group. Overall, what they showed is despite the varying degrees of renal dysfunction, the improvement in bone density at lumbar spine, femoral neck, and total hip were quite similar between the groups, and the percent reduction in new vertebral fractures at 1 year were similar between the mild and moderate groups of renal dysfunction as well. Because there were so few patients in the severe renal disease group, they were unable to have any analysis from that group. But overall, and in terms of safety signals, there was one case of severe hypocalcemia in the placebo group and one moderate case of hypocalcemia in the Romosozumab group at 12 months. So it didn't seem like there was any significant safety concerns with hypocalcemia like we do worry about with denosumab. And in terms of worsening renal function, there was no significant worsening renal function between the Romosozumab and placebo at the 1 year mark. So for me, the take-home message is we know the efficacy of this drug from that's been reported from previous conferences, but now we can see that there's in terms of breakdown based on varying degrees of renal dysfunction, there seems to be maintained efficacy even up to patients with moderate renal disease. The only limitation for the study is there's very few patients with a severe renal dysfunction with an eGFR less than 30, so it's hard to extrapolate how to treat those patients going forward. Otherwise, thanks for tuning in, and for further coverage of ACR 2019, tune into RoomNow.com. Thank you.
Y su apply en Ecuador. En Ecuador, Romosozumab AQQG injection is used to treat osteoporosis, a condition in which the bones become thin, weak, and break easily. In postmenopausal women who have experienced a change in their lives. And in conclusion, is the technical information indicates that Romosozumab is only recommended for postmenopausal women and high-risk of osteoporosis fractures with warning of the small but significant increased risk of heart attack or strokes. Thank you very much.